Good morning, and welcome to today's BPC webinar on health technology and the policy path forward in 2026. My name is Jonathan Burks, and I have the honor of leading the Bipartisan Policy Center's health program, which is focused on how public policy can improve two critical elements of America's healthcare system: affordability and innovation. Today's event focuses on innovative health technologies, with a look ahead to key questions shaping federal policy in 2026. More than ever, health technologies are rapidly transforming the healthcare system, reshaping how patients access care, how providers deliver it, and how health systems and payers manage administration. If implemented thoughtfully, these innovations could help tackle long-standing challenges such as provider shortages and care gaps, including in harder-to-reach rural areas. BPC has long worked to help policymakers navigate the rapidly evolving landscape of innovative health technologies, including to support the approximately 60 million people in the United States who live in rural communities. We have advanced bipartisan solutions to maximize the value of telehealth and remote patient monitoring, and spent the past 2 years educating policymakers on the increasing use of AI in healthcare and the complex policy landscape governing these solutions. BBC is closely watching the implementation of the $50 billion Rural Health Transformation Program, whose purpose is to transform the way care is delivered in rural communities, in part through the use of innovative technologies. Today's discussion builds on this work and convenes experts to discuss the role of policy in shaping how those solutions impact health systems, providers, patients, and rural communities. We'll start with keynote remarks from Amy Gleason, Administrator of the DOGE Service and Strategic Advisor at CMS, who will offer her perspective on how the administration is working to leverage technology in healthcare. Just this morning, HHS unveiled its strategy to leverage AI to transform agency operations. And over the past year, CMS has taken steps to modernize the nation's digital health ecosystem, including actions to develop a nationwide provider directory and expand data sharing capabilities. These initiatives aim to build a digital health ecosystem that improves patient outcomes, reduces provider burden, and drives value. Following Administrator Gleason's remarks, Dr. Lena Nguyen will moderate an expert panel discussion featuring Dr. Ativ Malhotra from Brown University, Dr. Miki Tripathi from the Mayo Clinic, and Jennifer Stoll from OCHIN. Dr. Nguyen is an emergency physician and a columnist for the Washington Post. She's also a member of the board of directors here at BPC and therefore kind of my boss. With so many experts to hear from, there's no time to waste. So, with no further delay, let me turn the Zoom over to Amy Gleason, who came back to government service a year ago this month after a distinguished career as an entrepreneur and senior executive across a range of healthcare and technology firms. Amy, thank you for joining us today. The floor is yours.
Thank you so much. I'm so excited to be here with you all. So in July, we announced the CMS Health Tech ecosystem at the White House, and it was different than past initiatives because it didn't use regulation to bring change over several years, but instead it is a voluntary effort to drive results quickly, in fact, just in months. As a recap, there were a few main parts to the ecosystem announcement. First, we wanted to fix interoperability once and for all. After many years of regulation, interoperability should work on paper, but the reality is that it is still too hard for patients and providers to get the information that they need. The digital health ecosystem that we launched created a CMS interoperability framework as a vision and framework that allowed us to ask those in the industry who are ready to move forward to prove that we can solve the roadblocks that still exist. This framework puts patient access front and center and aims to solve some of the stickiest challenges, especially around trust. As part of that effort, CMS announced that it is doing its part to create some common infrastructure to help with interoperability and trust. First, CMS is building a national provider directory that can help people and technology know how to contact providers to get health information. And second, CMS is adding modern identity verification to the National Provider Directory and to Medicare.gov. Through modern identity solutions, we can improve trust and data exchange by allowing those receiving requests for information to know that it is actually the person requesting them. They are who they say they are, whether it's a provider or patient. And although this infrastructure is very important for a lot of reasons, the main goal of fixing interoperability for us is to empower patients with modern technology, the same kind that we use in every other part of our lives, and to give patients personalized care and support at any hour of the day through the apps that they choose, wherever they are, including rural America. The burden to get their own information has been way too high for patients for too long. As an example, my daughter has her information stored in 47 different patient portals, which is virtually impossible for anyone to manage. The CMS health tech ecosystem changes this by allowing her to access her information from all of her providers without having to know where it is stored or to have to remember different portal usernames and passwords. She can do all of this with any app she chooses in the ecosystem. To get started with empowering patients, we're focusing on three main use cases. First is kill the clipboard, allowing the patient to share their information directly with their provider by scanning a QR code or tapping a smart health card to share directly with their provider. Second, once they have their information, we can put conversational AI on top of that in a way that it knows their information and personalizes it for them, and also in a safe way. And lastly, straight up the Maha lane is diabetes and obesity prevention and management that is personalized using your clinical information. So in July, we began with 60 brave companies who pledged to meet these goals quickly by the end of the first quarter of 2026. They raised their hands and committed time and resources to stop saying, we can't do this because, and instead to find ways to say, yes, we can. These companies pledged in categories that include patient-facing apps, EHRs, providers, payers, and data sharing networks that will respond to queries from patients, providers, and payers. Since then, the momentum has been incredible. We now have over 400 companies who have pledged to meet the first quarter goals. And we've added a new category called Friends of the Ecosystem for companies that offer key pieces of solution, even if they can't meet the whole pledge category themselves. This entire effort is fully voluntary, but the excitement is palpable. We now have 13 different technology working groups that are all led by volunteers who have stepped up to lead the way to find solutions to these technical and operational challenges that stand in the way of our pledge date. And we also have representatives from hundreds of companies working shoulder to shoulder, collaborating and not competing to find solutions. The CMS did not dictate the answers. We instead challenged the industry to prove what's possible, and they are doing it. On November 13th, 180 companies came together and demonstrated real progress at HHS. We had patient-facing apps pulling clinical records from CMS-aligned networks based on the patient's request, and then delivering personalized guidance back to the patient. Those same apps shared relevant data back to the patient's providers through their EMRs. Payers showed real examples of reducing administrative burden, like letting providers request a digital insurance card just using a few demographic fields. And CMS released its first provider directory sandbox that is working collaboratively with the private sector on accuracy, identity, and better interoperability data. And CMS reaffirmed that it will add modern digital identity to Medicare.gov and that Medicare will also respond to patient and provider queries for clinical data in the first quarter. The momentum is strong and the technology is real. The ecosystem is proving right now that all of this is possible. But there has been one thing missing, a payment mechanism that supports technology-enabled care and the providers who use it. We needed a way for technology-enabled innovation to get paid for driving outcomes, and we needed providers to get paid for referring patients to those tools and for monitoring and addressing their care plans. That is why we are so excited today to talk about the new access model that was announced this week. Access is going to supercharge the CMS health tech ecosystem and all of healthcare. It rewards outcomes, it encourages continuous engagement instead of just reactive care, and it supports a future where innovative apps, trusted relationships, and real-time personalized support are part of how we deliver care every day. Access now gives us a way to scale it, reward it, and make it real for millions of patients. Additionally, CMS is distributing $50 billion through the Rural Health Transformation Fund to help states redesign care delivery in rural communities. States have submitted applications and they will be evaluated before the end of this year. Digital access is central to this program, and the health tech ecosystem provides the tools, identity, data liquidity, APIs, and trusted directories that rural providers and critical access hospitals need to participate fully in a modern health system. Transformation cannot skip rural America, and with these programs aligned, it won't. My ask of you today is to get involved. Take the pledge if you haven't, either as an app to kill the clipboard, provide conversational AI, or manage diabetes or obesity, or as an EHR, as a healthcare provider or health system, a payer, or a network. And if none of these fit you exactly, but you want to be involved in the change, then join us as a friend of the ecosystem and get involved. The easiest way to find the site is just to Google CMS Health Tech Ecosystem, and on that page, there's a form to fill out if you'd like to pledge. Once pledged, you get added to our Slack community and you can join the work groups and speak up for how you want this to work. CMS is not dictating the answers. We're asking you to help us find solutions. And we also need smart and talented tech people to come and join us here at CMS on this journey. We are hiring all kinds of engineers, product managers, designers to come and join us. It can also just be a sabbatical. So you don't have to come and be a Govy for life. You can come for 6 months or a year to come join us. So we would love to have anyone you would recommend. Please come see us. U.S. DOJ Service is helping with that hiring effort. So the easiest way is to go to usds.gov and apply there, or you can send me your referrals directly. Thank you so much for having me today, and I look forward to hearing the panel discussion. And now I will invite Dr. Lena Nguyen to come and lead the next session.
Thank you so much, Amy, and thank you, Jonathan, for your opening remarks. Thank you also to the Bipartisan Policy Center, on whose board I have the privilege of serving, for convening this conversation at a critical moment when health technology is evolving at extraordinary speed. We know that patients are using digital tools in their daily lives, clinicians are adapting rapidly to new ways of delivering care, and policymakers are trying to ensure that innovation improves access, quality, and cost, especially in rural and underserved communities. That's what we're here to discuss today, for which I'm joined by a distinguished panel that I will introduce now. First is Dr. Ateev Mehrotra, who is the chair of the Department of Health Services Policy and Practice at the Brown University School of Public Health, where he leads research on how new models of care affect patients and health systems. We also have Jennifer Stoll, who is the Chief External Affairs Officer at OCHIN, an organization that supports community health organizations nationwide and operates its own EPIC platform to advance care in rural and under-resourced settings. And then we also have Dr. Mickey Tripathi, who is the Chief Artificial Intelligence Implementation Officer at the Mayo Clinic, where he oversees the development and deployment of a wide range of AI solutions across clinical and operational domains. So I will turn to our panelists in just a moment. I wanted to let the audience know that we'll be structuring this conversation in 3 parts. We'll have a discussion, a level-setting discussion about use cases and where health technology is already being deployed. Second, we'll talk about the impact and what we know based on research, especially with a focus on rural areas. And then we'll have a longer discussion about policy. For all of these questions, I invite the audience to submit questions. I will be peppering into our panelists your questions throughout. And I also received a list of your pre-submitted questions, a 2-page list. So thank you all for submitting so many questions in advance, and we'll be asking some of those to our panelists as well. So I'd like to begin by asking the 3 panelists today to again help us to level set. What are the most important use cases right now in telehealth, remote patient monitoring, and AI? Where in these, for example, are making a meaningful difference for patients, clinicians, and health systems? Ateev, if I can start with you, please.
Well, thanks, Lena. And it is, when you think about health technology and how it's in healthcare, it's a bit bewildering. There's so many different types of health technology that are being used. I might just start in level setting by focusing on 2, one in particular that's most familiar to Americans, which is video and phone visits. I think most Americans by now have had a video or phone visit with one of their clinicians. It obviously grew dramatically during the pandemic. I think what gets less as people are less aware of where do we stand right now. After that huge spike during the pandemic, there was this pretty substantial drop as in-person care started to reemerge. And we're now roughly about 1 in 20 visits in the United States are a video or phone visit, with obviously certain clinical areas where we're seeing a lot more use, mental health in particular, but in other clinical areas we see very little. One interesting and important thing, and I think that will sort of lay the foundation for some of our further conversation, is what happened during the recent government shutdown, where we did see when Medicare stopped paying for visits, we saw about a 20% decline, at least in the short term, in the number of telehealth visits. And so that's something we're going to have to think a lot about, and we don't know what's going to happen in the long term. Another application that I think would be useful for the audience to be aware of is RPM, or it has an acronym, typically stands for remote physiologic monitoring. And this is a delivery model that I think is less familiar to most Americans, but where patients are on a regular basis, often daily, are submitting data like blood pressure measurements to their doctors, and their doctors are then responding whenever there's an anomaly or some change needs to happen. And that's an area where it started to grow during the pandemic, but it has continued to grow very, very rapidly in the healthcare system, in particular for chronic illnesses such as hypertension and diabetes. So I wanted to also make that another potential thing that the audience should be aware of health technologies. And these are just two of a huge myriad of different applications that are out there. So let me turn to my fellow members here if they want to comment on some of the other applications.
Great, Jennifer.
Yeah, good morning, and thank you to the BPC for having me here today. Yeah, and I think it's important to kind of level set in the Ocean Collaborative. We support rural and underserved communities across the country. And we think about technology and the advancement in terms of really people, process, and systems, right? You can have the best technologies, but if you don't have the support and the people to be able to implement them, you have very expensive doorstops that you just bought. What we're seeing right now is an excitement toward being able to drive reduce provider burden and also improve revenue cycles because we're in a massive innovation shift within the rural and underserved communities that we're supporting. We are seeing a tremendous amount of excitement, and I know Mickey will elaborate on this further. But a tremendous amount of excitement around being able to use AI tools to really speed up the revenue cycle process, to be able to support payment and increase payment to those that have the least amount of resources. And also, I think we're seeing a lot of excitement about tools that help reduce provider burden because at the end of the day, we really need to keep capacity in our rural areas and make sure our primary care providers stay in practice. They're not retiring earlier or they're not leaving. So anything that the organizations that we support can do to adopt tools to improve charting, to reduce in basket, to be able to better effectively communicate with patients in real time is something they're really excited about. We're deploying a lot of large language models, ambient scribing right now. And we're seeing in our evaluation significant time back for each provider, around 6 minutes per patient, which adds up over the course of a day. So there is a lot of excitement. The reality, though, is affordability of a lot of these products are still challenging. So we can talk more about that, but I appreciate the question. Thank you, Leah.
I'm sure that cost is going to come up as a key question. So thank you for previewing that. But let me turn to Mickey. I'm sure you have a lot to say about how AI is already being widely implemented.
Great, thanks, and thanks for the opportunity to be here today. The first thing I guess I just we think about AI at Mayo Clinic, and I think at large as being a part of a trajectory that we're on. That if we think about the last 15 to 20 years, we've been investing as a country, and especially over the last sort of 10 to 15 years since 2010, making huge investments as a country in transforming the healthcare system from a largely paper-based system to one that is a firmly digitally founded system today. I mean, you'd be hard-pressed to find someone who doesn't have an electronic health record and who doesn't have access to their own records via a patient portal. And I certainly take Amy's point that, for patients who see many, many, many providers, they got 43 portals, which is a problem. But I think that just that step up from a paper-based world to a digital world, which has been a tremendous amount of work on the public and the private side over the last 10 to 15 years, is an enormous step up and positions us now to be able to take the best advantage of these transformative technologies, these AI technologies that in some ways you can think about the building of that digital foundation with electronic health records as being a prelude to this moment. Because one of the challenges we've had is that as much as electronic health record systems and digital data, I think, has stepped up our ability to do more in healthcare, we face the challenge that so much of that information is still siloed, is still unstructured, is hard to mobilize and to be able to draw real meaning from. The World Economic Forum estimates that something like 97% of the data that we have in healthcare goes unused beyond the original documentation. And a part of that is because it's so hard to manage. It's so siloed. It's so many different modalities. You have images and you have tracings, and increasingly you have voice, and you have unstructured data and structured data, and it's all, sort of siloed within provider organizations and payer organizations and healthcare organizations, and very difficult to mobilize and bring together and to be able to use effectively. With AI, we now have the opportunity to be able to get an amazing amount of signal from that noise, to be able to say all of that information that for us was almost just a pile of unusable information. We're able to say we can actually draw inferences from that, we can draw meaning from that, and we can understand it better, and then take steps to using agentic solutions and other kinds of things to actually mobilize it in ways that improve patients' lives. So as we think about that at Mayo, we have, I guess I would categorize it in a couple of different ways. One is we have a whole set of things that we're focused on, which is what Jennifer had alluded to, which is how do we help humans do things better, faster, and hopefully more efficiently than they're able to do today. So it's things that humans are doing today. They're doing documentation, they're doing revenue cycle, they're aggregating records and faxes. Mayo alone, we get something like 5 to 7 million faxes a year. That we then have to process and sort of figure out that how do we get it to the right provider? How do we make sure that they're able to distill the information that they need for that particular encounter and that particular patient? But the ability to do that at scale, to be able to do that in a much more efficient way is a whole set of technologies related to things like that. So for example, we have a technology called record time, which allows us to take outside materials, faxes, handwritten notes, literally, because we get patients from around the world, be able to rapidly synthesize those, be able to apply metadata to those. So that means to categorize them so that a provider, when they're sitting in front of the patient, is able to say, I see that there are 17 different types of records here now. Here's a lab result. Here's a post-operative note. Here's a medication a prescription, and then they're able to quickly figure out what they need, and then be able to bring that to bear in the decision making and the conversation with the patient. So whole set of technologies about how do we do things, allow humans to do the things that they're able to do better, faster, and more efficiently than they're able to do today. Now there's a whole new frontier, I think, which is about how do we use these technologies to do things that humans literally can't do today. And we have a whole bunch of technologies that are focused on that. What do I mean by that? We have the multimodal models that we're building here at Mayo, foundation models that take different types of, you're familiar with the large language models, ChatGPT and Claude and all of those, which, remember, the name language, large language model, means it's only applied to language, right? All that, it's very powerful, but all it does is language. Well, what if I can bring pathology slides? What if I can bring images? What if I can bring voice and say, how do I combine that with electronic health record data, which is language or numbers, and combine all of that in the same powerful ways that the large language models do to language, but allow us to get insights and inferences that we're not able to get today. So two things I'll point to. One is we have a set of technologies now that quickly examine chest x-rays and provide information to the radiologist in real time to be able to allow them to drill down into what are anomalies, so that they're not spending time, sort of trying to figure out the overall chest X-ray and spending an inordinate amount of time on every one of those. That technology right now looks like it might save a radiologist 35 to 45 seconds per X-ray. You may think, how much, well, how much is that? Well, it turns out that 80% of patients who come to Mayo get some form of imaging. The most commonly ordered type of imaging is a chest X-ray. Our radiologists will review something like 150 to 175 chest x-rays per day. So you save them 35 to 45 minutes and reduce the cognitive burden so that they can focus on the things that they as humans with their human judgment need to focus on. Tremendous advancement just in efficiency and in quality. The other thing I will point to is the ability to use AI to, for example, do earlier detection of something like pancreatic cancer, which we have work going on right now, to be able to say, how can we look at imaging studies at pathology on patients who eventually got pancreatic cancer, but we can look historically back at the data, and we've got really early positive results of AIs looking at early imaging that the providers themselves did not detect early signs of pancreatic cancer, but the AI is looking at it and saying, that's pancreatic cancer. That is a visually occult or a tumor that was not visible to the human eye, but the AI detects it. So just an example of things that now we're starting to expand the use of technologies to do things that humans are not able to do, which I think is a tremendous new frontier.
Thank you so much, Mickey, and thank you to our panelists for opening so strongly and giving us so many different use cases to further our discussion. I want to move on to the second component of our three topics and want to spend most of the time on the last, which is on policy. But we do have a number of audience questions to get to as well. Atif, I wanted to come to you to again give us a level setting about what do we know so far about the impact of these technologies that we discussed on access, outcomes, and cost. Where are they delivering value, and where is the evidence still emerging?
Yeah, I think that's a really critical question because many people, when they hear about these technologies, including myself, make assumptions. Oh, this is going to be awesome. This is going to really transform access, quality, and spending. And the empirical data isn't always so positive. And so I think it's a good level check for us in the sense that in some cases, these health technologies haven't been as helpful as I had envisioned. Maybe I'll just start with, again, moving away from what Jennifer and Mickey were talking about, which was really exciting, cutting edge stuff, and going back to the video and phone visits. And with the video and phone visits, we have seen it depends a lot on the application, but in net, I'm not seeing in my results and the analyses that others have done that transformative aspect in terms of improving quality. We do see some improvements, and it depends on the clinical area, but it hasn't been that transformative aspect. Certainly, it's improving access to care. But here again, there's all these caveats. I had gone into this work hoping that what we would see is in rural communities those communities that often have the most difficult access to care would be using these technologies the most. And unfortunately, we see the opposite, where these technologies are less used in rural communities on average across the country. And in some ways, unfortunately, that difference that we've talked about, the urban and rural divide, has widened because of those technologies. I'm not saying these technologies are bad or that it hasn't helped some people in rural communities, but it hasn't been that decreasing that divide as I had hoped. And lastly, a lot of times people have assumed that these technologies are going to save money. And in some cases, they probably will. But again, a case in the video and phone visits, we see that it does result in more care, which more care means more utilization, and more utilization transforms into increased spending. Not a huge amount, but it has resulted in that. So these are just some interesting, and I can go into more detail if we want to, but examples of some of the results that we're seeing out there in terms of how health technology is impacting access, quality, and spending.
So let me throw one more wrinkle at you, Atif, if you don't mind. We have an audience question that touches on this question of cost that Jennifer had mentioned. And the question is, do you expect health tech innovation to increase or decrease the cost of healthcare in the future? You had talked a little bit about this, Atif, but if you could expand on that and also talk about another question, which is what would be the impact on the cost of primary care that increasingly utilizes digital and technological services?
Yeah, it'll be really interesting to get Jennifer and Mickey's take on this. I would generally say that if we look at the history, and now I'm a health policy wonk, that we think about different technologies that have been introduced into the US healthcare system, from new drugs to new devices to new surgeries in general. They make a dramatic and positive improvement often in our health. But in general, when we introduce new technologies, they increase spending. They lead to more people getting care and different types of care. And therefore, I think that on average, one should assume that health technologies should largely also be the same. We shouldn't make an assumption they're going to decrease spending because in most cases, technologies increase spending. Now, that's not true across the board. And I think Jennifer touched upon it and Mickey did also, which is that if these technologies focus on making our clinicians more productive. And productive sounds like a negative thing, but it could be a positive thing in terms of being able to provide more care and at the same time drop their price so that if the radiologist that Mickey was describing is able to read more chest x-rays more quickly, and therefore we decrease the reimbursement for the chest x-ray read, then you can start to see how technologies can save money. But I think that that's the kind of pathway that you're most likely to see those benefits. But let me turn to, or if you don't mind, others and see what our panelists and what they think.
Atif, if you don't mind, because I have so many questions that are coming in from the audience that I want to make sure that we get to as well. Jennifer, I would love to hear your thoughts about cost, but I also want to work in an additional question as well, which is given the persistent issues, and this is another audience question, given persistent issues with electronic medical records such as Epic, how can healthcare systems utilize existing technologies to share medical records more seamlessly? What incentives do providers and health systems need to be fully interoperable? If you can comment on that, and then I'm going to turn to Mickey. You're welcome, both of you, to comment on the issue of cost, but I also have some very specific other questions to ask you about as well.
Thank you, Lena. Yeah, so again, we come back to people, processes, and systems, right? And thinking about where people's starting points are. It is not uncommon for OCHIN to support a critical access hospital with outpatient clinics and a skilled nursing facility on 3 or 4 disparate EHRs. And as we help go in and modernize their EHRs, and we're standing side by side with them, the biggest challenge we have with technology is the use of it. We see that one of the biggest gaps of using an electronic health record is we're not using all the capacity and all the work and the opportunity to use the EHR to its fullest, because we are so under-resourced in terms of people and the skilling that they need. And so, one of the things that we think about is we do a lot of training, skilling and training. And as artificial intelligence is coming to our rural communities, we've got to make sure that we have the right training and the skilling in place to be able to navigate that. And I know Mickey touched on it. One of the interesting things we just did in partnership with our HRSA partners is do an AI boot camp for the California Telehealth Resource Center. That was digital skilling that we pushed out, and it is in desperate need. I think the workforce component is really, really important. But we are only going to be able to get the utilization of these tools if we have the right people and the right systems in place to really navigate that, and the skills that are needed to be able to support the transformation. So that's one of the things I know I was going to talk about in the policy section, Lena. But thinking about workforce development, I can't not bring the people part of that into technology, and otherwise we are going to run our rural communities over with artificial intelligence, the management of the tools, the navigation of the maturity of these models, and the responsibility of deploying the right model for the right patient population.
Thank you for that. I was another question that came in that let me just direct to you as well, because it does dovetail on rural care, is how can we ensure that federal funding fosters improvements in care delivery in underserved rural areas and not just experimental participation?
Yeah, I mean, you're talking about sustainability, and we have an incredible opportunity from HR1 and the $50 billion getting out to our rural communities to really transform care. We had provided feedback to states to think about it in terms of building a continuum of care over 5 years to make sure that we are helping level set where everyone is in rural communities, and then building on top of that in a thoughtful and responsible manner over time. And that's what we believe is we have to all start with a good basic foundation and the skills in people to be able to really navigate the complexity of new tools and opportunities to transform care with new models of care and all the exciting things that are coming out of our partners like Mayo and others. But they need to be able to have a good basic infrastructure, because their starting point is so much further behind than an organization like a Mayo, that they have to catch up to be able to continue to have and make sure that we're consistently trying to close that gap. And we need, again, people and processes and good infrastructure to be able to do that. And that's what's so exciting about the $50 billion coming out of the rural health transformation, being able to focus and have that investment, that one-time investment over 5 years to really change the trajectory of our healthcare, and then think and have the capacity to innovate over time.
Thank you so much. You talked about workforce, and so I'm going to direct this next question to Mickey. This is a two-part question two very different questions, but perhaps, but I think both will be, both are of interest to our audience. The first is, again, both of these are audience questions. The first is, what are some opportunities for technology and AI to address workforce shortages, particularly in long-term services and supports? And then the second one might be a bit unfair, but Mickey, I'm going to ask it anyway, because this is from Bill Hoagland, and he's citing former FDA Commissioner Califf as recently having said, I do not believe there is a single healthcare system in the US capable of validating an AI algorithm put into place in a clinical care system. Do you agree with that? Mickey, I think that you are on mute, and so thank you.
Thanks for that. And you know, maybe Dr. Caleb is speaking about Duke, but you know, at Mayo we feel like I'm only joking. I completely take the point. Let me take the first point first. You know, one of the things, and I was in the administration, in the previous administration, in the Biden administration, in the Department of Health and Human Services, and as we were thinking about AI and thinking about the, you know, sort of the different workforce considerations, one of the things that, you know, that we wanted to make sure people understood about healthcare is that our workforce issues are related to not enough workforce in many, many cases, not everywhere. But the challenge that we have is that we don't have enough workforce, and we have an overburdened workforce who aren't able to, you know, to meet the need. And so the opportunity that we wanted to be able to, you know, have the industry take the most advantage of is being able to use these technologies to allow the workforce to be able to work as productively as they can at the top of their skill sets as they can, and take as much of the rote, bureaucratic, administrative kind of work off of their hands so they could be working at the top of their professional game. And that's what we're trying to do, you know, here at Mayo. So I mentioned some of the administrative kinds of things that we're putting in place to be able to relieve staff of the burden of chasing down faxes, scanning in those faxes, trying to, you know, sort of render and catalog those faxes and index them for the providers to be able to say, how do we automate those tools so that they can be doing more in the way of actually being able to derive insights and helping more directly with patient care, for example. We also have a set of technologies that we're now looking at that would use avatars, for example, either a video or an oral avatar, to be able to engage patients directly in things that right now we're very short-staffed on, and means that patients have to wait a long time to be able to get the kinds of interactions that they need to be able to get for something that an avatar might be able to you know, handle very well. And in some circumstances, the patient may be able to feel more comfortable with that. What are the things I'm talking about? One is genetic counseling. In almost any setting, you'll find, for those who haven't tried to get a genetic counseling visit, I myself tried to schedule one here in Boston. It was literally 10 months away before they were able to schedule a genetic counseling visit. And same thing at Mayo. We have a shortage of genetic counselors and a growing need. But we're experimenting with an avatar that can actually have an immediate interaction with the patient to be able to just collect basic information about family history, other kinds of information, to be able to do the initial assessment, to then be able to guide, you know, what might be the most appropriate next visit for that patient. And that just allows us to extend, you know, sort of the staff to be able to, you know, allow them to get more of that initial intake, and it's a better patient experience for the patient, you know, for patients who feel comfortable with it. And obviously we want to be able to provide them with what channel works best for them. Some feel comfortable with a video avatar, some feel comfortable with an oral avatar, some people just want to talk to an individual, right? And we want to be able to offer all of those things to a patient, some of whom might be willing to say, you know what, I'll talk to a video avatar if it means I can do it tomorrow, versus waiting, you know, 11 months to talk to a human. So that's one example. We've got a couple of other examples as well, where you have nurses, for example, who work with individuals on the management of Foley catheters once they leave the hospital environment and are going to manage that at home. That's a nurse, literal nurse having an analog, real-time, synchronous conversation, and that takes a long time to schedule, and it's a lot of work. It turns out that there's a lot of standardized, sort of conversation that can happen with that, and that allows that the extension of that nursing staff, which of course in every setting right now we've got shortages in. So I think there's tremendous opportunity there to be able to have our staff have more agency over the work that they're doing, and also to be able to extend the capabilities of the staff in ways that allow patients to have better access to the system overall. In terms of, Dr. Califf's comment, I think evaluating these things is very, very difficult and is very, very challenging. And one of the things that, that we find is that my job is implementation. So as my title implies, Chief AI Implementation Officer. So I am on that end of it to say, all right, the solution now looks like it's mature. Now, how are we going to decide whether it's ready for prime time? And the challenge with, with the evaluation and the validation of these is a couple of things. One is it's people, technology, and process, as Jennifer was talking about before, that you could have a very, very, very good technology, but if it's poorly implemented, then you're going to have all sorts of safety issues, along the way, even though the technology did everything that it could. The other challenge is that for each of these solutions, they've got a different type of, sort of validation that's required. The kind of solution that I was talking about before for assessing, our early pancreatic cancer is very different than the validation you'd need for something that's summarizing records, from faxes. So you have to tailor that kind of validation to, to the type of technology. I think that we do a very good job, but we obviously can do better, and we've got a lot to learn. It's still very, very early. So I think that we all have to take that into account as well.
Thank you, Mickey. This next question is directly to Ativ, because this person says, to Dr. Marocha's point, there is a significant resource cost of training rural staff to use technology tools. These providers are frequently reluctant to step away from their patients to learn new systems and tools. Are there strategies that you might recommend or utilize that facilitate this adoption? And then I had a similar question about that I'll pose to you as well, about how to ease the cultural shift and upskilling that may be needed to accept new technology.
No, I think the question really addresses a key point here, which is, and I know Jennifer and Mickey have also talked about this, which is that these technologies, you just don't wave a magic wand and they get implemented. They take resources, time, effort to try to get there. And if you take a resource limited organization that may not have the infrastructure that a Mayo has or OCHA's support, is really going to struggle with that. And just to emphasize that, I just thought we did some recent work on telestroke, which has been really helpful in terms of really improving outcomes for patients with stroke care, in particular in small rural hospitals. And yet what we found is the small rural hospital was the least likely to have that technology. Just really illustrate that issue. What does it take? I think it does require targeted resources and targeted support that organizations like OCHA and Mayo and others are going to be providing. And we just can't assume that those providers just de novo are going to be able to do it, because you have a small rural practice. It takes a lot of, I don't know how I would start. It takes a big team to implement these technologies. And so I think that's the key point. I think maybe Jennifer and Mickey can probably comment a little bit more on the details and some of their own efforts in this space.
All right. Thank you so much. Jennifer and Mickey, if you want to comment briefly on this, and then I'm going to turn to our last topic, which is on policy. Jennifer and Mickey, anything on this issue of upskilling and adoption?
Yeah, I mean, in terms of upskilling, I think it's always important to meet the organization that you're supporting where they are and understand where their key pain points are. And honestly, that's what folks are doing right now in terms of artificial intelligence. They're operating just in time and looking at where their key pain points are and solving the problems of today. Thinking about predictive analytics is absolutely not on the roadmap for many because they're trying to keep their doors open in service to their communities. So being able to understand and be able to show the value of where some of these tools can go. The other, and also how do we provide, as Mickey was talking about, being able to show them that adopting various tools will help them be more efficient so they can constantly. There's a higher level of turnover in rural communities and safety net providers that we support. So making sure that part of this is also the constant retraining that we have to do because the turnover is so high, but making sure that they understand the value of these tools and to their current practice and where it's going to take them tomorrow. But so many of the organizations that we support are just in time. And thinking about innovation is more of a long-term process. So, we have to stand side by side with our communities and who we're supporting and training them on where they are today.
Yeah, I guess the only thing I would add quickly is, and it relates a little bit to the validation question, but to this question, I think one of the things that I think we all need to recognize, and I certainly do it at a micro level within Mayo, but I think we need to think about it at a macro level as well, which is that, what are we comparing these technologies and the use of these technologies to? Our system, our healthcare system in the US is highly imperfect, to put it mildly. We don't get the kind of performance that we need from from the healthcare system, especially for the amount of money that we put into it. One dimension of that, I think, and so as we think about these technologies, we want to recognize that something like 80% of counties in the US do not have a cardiologist within an hour of the people who live in the county. Now, the choice for those patients is zero versus perhaps an AI tool that could give them some type of access to information from a cardiologist and interaction with a cardiologist that gives them some type of healthcare that they're not receiving today or don't have easy access to. I think we have to take those into account as well, that we can provide more access, and we need to compare it to what people have today and see if we can make incremental improvements for them that actually improve their lives.
Thank you so much. So we have about just over 10 minutes left for the discussion about policy, although of course we've been incorporating that throughout. And so I wanted to pose this two-part question for each of you. And Mickey, I'll start with you this time, which is, as we look towards 2026, what can we expect from federal policy is the first part of this. And then the second is, what's on your wish list? What are specific federal actions that you think are the most needed to support responsible technology adoption, whether it's through the Rural Health Transformation Program, through CMS, reimbursement changes, through clear oversight of AI or anything else? So what can we expect? And then what's on your wish list?
I don't know. I want to ask Amy that question. No, I think that, from my perspective, I think, one of the things that, if we just think about interoperability and technology just for a second, I highly commend Amy and the team for, pushing forward with, all the infrastructure that we've put into place over the last 10 years. Now, count that as both physical infrastructure, electronic health records, and transforming a paper-based industry to one that is, the vast majority is actually electronic and digitally native in certain ways, and being able to now say, let's push forward on that and get the real promise of all those investments. So, highly commend the team for doing that, bringing people together to say, everyone do that, and the regulatory infrastructure that now is being taken advantage of as well with the forward push to that. That said, I think one of the challenges that we've had is that at the end of the day, things like interoperability, they're not technology problems at their core. They are business incentive problems, and they are structural problems related to the way we pay for care and how people are compensated. So I also highly commend, as Amy referred to, anyone who wants to look at the announcement of the Access Program, which is a model that does explicitly start to say, how do we pay people for the uses of technology that improve outcomes? And it's just a model. It's going to take 10 years for the model to complete. But we've got to start somewhere. And I think it's a great start to say, how do we start to incentivize the uses of technology in ways that improve patients' lives? Right now, they just get paid for, every single procedure, every single process. And that's not the way we're going to get to the place we want to be as it relates to that. So I think that moving as aggressively as possible forward on helping to change the business model for healthcare so that we are actually paying for quality and better outcomes, and not paying for just doing stuff to people, I think would be, an important step. And CMS obviously plays a very, very influential role in that. As it relates to things like devices, for example, I think that having a little bit more flexibility on the ways that we think about the uses of AI technologies that provide a little bit more recognition, for example, that entities that are already covered by a lot of regulation, healthcare organizations like provider organizations, like payer organizations, others already have a lot of regulations that we have to follow, whether it's HIPAA, Joint Commission, Medicare, on conditions of participation. It goes on and on and on, both the federal and the state level. Recognizing that as we think about the uses of AI, for example, and in a sense, giving credit for that, so that we have more flexibility to be able to use those AI technologies within the the regulatory requirements that we already have, I think will give us a lot more flexibility in being able to bring these technologies to bear in a much more effective way than we're able to today.
Thanks so much. And Jennifer, what do you expect, and what's on your wish list?
Yeah, I think it's a great question, and I appreciate Mickey teeing it up. Thinking about what we expect for 2026, I think I'm excited to see the health technology ecosystem continue to evolve. And I'm expecting it to continue to evolve and thinking about, continued focus on using the Rural Health Transformation Fund and those dollars, hopefully being able to move through the states and really driving a lot of that alignment through the states and out into our rural communities. Ensuring that the money gets out into our rural providers is really fundamental, which also talks about wish list and policy. So then jumping to my wish list, our wish list is really to think about it in terms of, investments in our rural communities and this one-time investment and opportunities to build the infrastructure that they need to be able to be competitive and innovate long term, and making sure that there are dollars available for hosted, supported EHRs is absolutely critical. We are also hoping that this is an opportunity for states to modernize how they're looking at data themselves. States are challenged, and I can tell you we send tens of thousands of reports all over the country, and the reporting is not necessarily digitally enabled. We still send a lot of smart sheets and faxes in reporting data, and that is a great way to improve efficiency and automate in a modernized way. So that's on my wish list. And then finally, thinking about workforce development, making sure that we are investing as a nation in our workforce for tomorrow and making sure that we are knowing how to navigate machines that are going to be extraordinarily smart and that we have the right continuum of care access and capacity for our rural communities and our underserved communities as we are moving forward in the world, right? If we don't have the right skilling, we're not going to be competitive as a nation. So we need to make sure that we have the right skilling to be able to navigate what is coming at us at rapid fire pace. So that's my wish list.
Thank you. And Ateeb, can't wait to hear yours as well.
What I'm hoping and expecting is that in 2026, to be super concrete, we finally resolve this whole issue of Medicare and telemedicine or telehealth visits. We've been kicking the can down the road for several years now, and it's really impeding progress because health systems and providers don't know whether they should invest in this technology. And as I alluded to in my opening kind of comments, we're already seeing to see some negative impact of this. And this is a bipartisan issue in terms of reimbursement. So really hoping that we see some permanent reimbursement for that. And there's certainly a number of bills that are being considered in the Congress, but to actually implement one of those. On the wish list side, I guess it would be, this is going to sound a little unusual, but a little bit of a change in mindset about policy. I think in healthcare, we're very much focused on, hey, there's a new technology. Let's find the code that's going to pay for that technology. I have a new thing, AI avatar for genetic counseling. Where's the CPT code? And I think we need to change that mindset. As I alluded to in several of my comments previously, I feel that we shouldn't be paying for AI in that way. We should be looking for opportunities where AI can increase productivity and therefore use that productivity to actually decrease reimbursement. So just as in the latest fee schedule, the administration has had this efficiency gain where they have reduced reimbursement because clinicians have gotten faster at doing things. We should think about AI as being another mechanism so that we can improve productivity, increase efficiency, and drop prices. And that's going to address what I think is such a critical issue facing Americans, which is affordability. We all know that Americans are facing that. And the way we should be thinking about AI is how do we make clinicians more productive so we can drop the prices and make care more affordable. So that's a change in mindset in terms of what I'm thinking about for 2026 as a wish list.
Thank you, Ateeb. Sticking with you for a minute, one of the audience questions is on Medicare, and this is about what are possible policy solutions for improving Medicare's antiquated, waiver-reliant reimbursement policy for technology-enabled services?
Yeah, and I think that understandably, in many cases, as new technologies have emerged, we've sort of created new codes and other things that sort of, and through waivers and or through the CPT committee and so forth, have been introduced. And I think what we probably need at this point in some of these clinical areas, I gave RPM as an example, and there's RTM, and there's all these other all these acronyms out there, CGM. We need to kind of revisit those and spend some time thinking, okay, now as these technologies have started to mature, how do we create a new system that decreases complexity for the clinicians? They're being overwhelmed by the different complex codes and reimbursements they need, and to make it easier for clinicians to use these technologies. I gave that one example, but I think we need that across an array of different other areas of where technology is being reimbursed by Medicare.
Thank you. I have an interesting question for Jennifer, and perhaps Mickey, if you want to weigh in on this one as well. This is about how does the one big beautiful bill both foster and hinder the use of healthcare technology? I think this will be the last question, the last audience question that we'll take today. To Jennifer first, and then Mickey.
Yeah, I think the challenge that we face is we're looking at least in resource constrained environments, we're going to be navigating a lot of complexity around how do we implement a lot of the changes around HR1. And I know states are thinking through that, and that's why thinking about automation and back to the reporting component and automating that is an opportunity to actually increase states' digital ability to navigate and use technologies to improve and being more efficient in various places. And so, thinking about MMIS, for instance, I know this starts getting technical, but thinking about how we're reporting things, I think is really key. But it is going to be challenging. We have to have some sort of capacity to be able to innovate. And what I'm excited about with HR1 is the $50 billion to rural health, and making sure that those dollars actually get out to our rural health providers is absolutely the opportunity here, and giving them some ability to navigate and deploy new technologies to innovate quickly.
Mickey, we have about 30 seconds. So I hate to ask you to be super brief, but you'll be our closing 30 seconds of the day.
Oh my goodness, I can say anything I want. I mean, I would just build on T's point, and which is what refers back to the access program that I was describing before that was just announced. And that specifically focuses on basically saying if you're using technology in a way that improves patient outcomes, we're not paying you for the technology. You figure out what technology you're going to use. But if we see an improvement in patient outcomes, you will be compensated for that. And that allows, I think what Atif was getting at is for providers to make the right choices themselves, to say which technologies do I think are going to work best in our setting for our patients, for me being able to demonstrate that I'm actually improving outcomes. I think that's the model that we need to head to.
Thank you so much. And thank you to all of our panelists for sharing their insights. Thank you to all of you for joining this discussion that's hosted by the Bipartisan Policy Center. I know this is a discussion that will continue to evolve, and we look forward to continuing the conversation as healthcare technologies and the policies guiding them do evolve in the year and the years ahead. Thank you very much.
Thank you.